Thank you for joining my presentation on oxygen toxicity. My name is Terrence Shenfield, and I have been a respiratory educator for the last 30 years, and I'm also the co-owner of A&T Respiratory Lectures. All of our content is AARC approved, and I hope you enjoy this presentation. The use of oxygen therapy dates way back into the 1800s. At that time, they were doing a lot of research with oxygen, and then in the early 1900s, they decided that oxygen could be beneficial to patients with pulmonary disorders. The number one disorder they really used it a lot with was pneumonia. So they developed this big tank, and they would actually put the patient inside the tank. And you could almost say that this is the first series of oxygen tents. And they would use this primarily with patients with pneumonia in the hospital. Over time, they began to realize the effects of oxygen, that oxygen is not all good. There are some side effects of oxygen, especially prolonged use of oxygen at high doses. So this presentation is going to speak about the toxicity that occurs with the use of oxygen therapy. So today's objectives are: why is oxygen toxicity such a big deal? I've been in the field of respiratory therapy for the last 30 years, and there was a time when we would not think twice about pumping up the oxygen to 100% if the SATs were around 89 or 88. And we would keep that high levels of oxygen on the patient for prolonged periods of time. Little did I know about the effects of oxygen therapy, and I don't want to take the blame for this, but little did the medical community know much about the toxic effects of oxygen. So I'm going to talk a little bit about the pathophysiology of oxygen. I'm going to speak about the clinical manifestations. I'm going to talk about some treatment options. And sometimes the impact of oxygen therapy can cause some kind of disorders with the lungs. So I'm going to talk a little bit about differential diagnoses, and then I'm going to speak about prognoses of patients who were experienced to long periods of oxygen therapy. So why is oxygen toxicity such a big deal? We have to understand that oxygen is a drug. Throughout my career, I have put hundreds of patients on oxygen therapy, and I've done a range of oxygen therapy from a simple nasal cannula to hyperbaric chambers. So I have a lot of experience with oxygen. A long time ago, I used to consider oxygen therapy to be not much harm to the patient. So if they're on a nasal cannula at 3 liters per minute for their whole length of stay in the hospital, it wasn't a big deal. But over time, we began to realize that oxygen, just like any other drug, has some toxic effects. So number one, we have to recognize that oxygen is a drug. Number two, we have to recognize that we need a physician's order for oxygen, and that we should be titrating the oxygen therapy based upon the needs of the patient. Part of the problem, one of the main problems with oxygen therapy, is a consequence of the production of reactive oxygen species. You might have heard of that. This is where you get too much oxygen in your blood and you create some metabolic pathways that get disrupted. Reactive oxygen species has been known to unravel DNA and cause a whole host of toxic effects, and I'll get a little bit more into that later. There are two groups of oxygen toxicity. First of all, they are patients that are exposed to very high concentrations of oxygen for a short period of time. And then we have the other patient who is exposed to lower concentrations, but for a much longer duration. The key point here, the longer you're exposed to high levels of oxygen, the greater likelihood you're going to create some kind of damage to the lung. Acute toxicity of oxygen therapy generally manifests itself in the central nervous system. Also, other kind of effects from oxygen toxicity is pulmonary effects. And both of these categories I want to talk more about a little bit later. I don't want to spoil the fun. Severe cases of oxygen toxicity can lead to cell damage and death. you have to understand that our bodies produce, when reactive oxygen species is in our body, that is what you call free radicals. And these free radicals are normally eliminated by the antioxidants our body produce. So, for example, when we breathe in air every day when we live in our life, our bodies produce antioxidants in them. Also, we get antioxidants from our diet. So we are balanced. But when you give someone high levels of oxygen therapy and we don't produce enough antioxidants to neutralize that, that is when the toxic effects take place.
Hey guys, in this video, I'm going to attempt to define ROS. This will probably come up if you're reading some of the studies relating to Alzheimer's or the benefits of ketosis. You might see ROS come up, and I just want to define it because it can be a little confusing, and in reality, it's pretty simple. ROS stands for Reactive Oxygen Species. Now, what the heck does that mean? So ROS can either be a free radical or a non-free radical involving oxygen. So this let's back up. What is a free radical? A normal atom has paired electrons. So if you have something that's paired, if you just envision it like a little disk and two little weights on the outside that spin, it's going to be very symmetrical. Nothing's going to happen. It's real nice and smooth. But if you take one of those electrons out and you have an unpaired electron and it starts to spin or move, it can really be a radical and move in a radical way and create destruction because it does not have a paired electron. Okay? So free radicals tend to destroy things. Now, the body makes ROS. Also, ROS can be generated from the environment as well, coming into the body. But the question is, why would your body make something that's destructive? That's the question, and this will help you understand what it is. Well, there is a natural process, a natural program cell death in the body. It's called apoptosis. And apoptosis is a condition where your body is actually killing off certain cells. Now, you might say, well, that's a bad thing, but actually it's essential for life, okay? Because your body has this urge to survive, so it's looking at the greater good. If there's certain cells that are mutated, altered, they're dysfunctional, then the body has to get rid of them. And that's when it produces ROS. So ROS has the ability to eliminate certain things that we don't want in the body. And if that involves killing off certain mitochondria or whatever, that's a good thing. So even your white blood cells produce these to actually kill off microbes. That's how it dismantles certain viruses. So your body has this interesting balance between free radicals or oxidants and antioxidants. So your body can make antioxidants as well, and you can get them environmentally. So you have this whole balance that happens in the body. So whether you're exposed to a certain stress, they call it oxidative stress. So let's say you have a certain metal in your body from iron, and that created a mutation in your mitochondria. Well, your body would produce this to get rid of that. The body does not want mutated cells. Exposure to chemicals, UV radiation that would come from external, or exercise produces higher levels of ROS to actually kill off the damaged muscle cells that need to be replaced. And it's replaced by the stem cell, so it actually just grows back. Hypoxia, decreased oxygen, pollution, smoking, infection. So your body is constantly cleaning all this stuff up and replacing it. So this is a real positive thing. So you probably in your house have hydrogen peroxide, and you can put it on a cut or a wound and see it foam up, because hydrogen peroxide is this, and that actually helps to kill off certain microbes. Okay, same principle. What's really cool is that ketones reduce the excess ROS in the body. So ketones can act as an antioxidant, and they protect the nerves. They're very neuroprotective. And this is why ketones are so good for the brain, and high sugar diet or high carb diet is so terrible for the brain because it actually causes so much destruction, and it leads to things like dementia and then eventually Alzheimer's. Anyway, I just wanted to explain what this is as simply as possible. Hopefully you understand it now, and thanks for watching. Hey, if you're liking this content, please subscribe now, and I will actually keep you updated on future videos.
I'm going to get into some basics of oxygen. I'm sure you all know this. Number one, oxygen is a chemical element. It's one on the periodic chart. Its symbol is O. It has an atomic number of 8. Number two, it is a drug, and actually it needs to be prescribed by a physician. So you need an order for oxygen because you really should take the oxygen level very seriously, and also how long you keep a patient on oxygen. And let's get a little bit more into chemistry. By mass, oxygen is the most third abundant element in the universe after hydrogen and helium. And it consists of 21% of our atmospheric air. So, a large portion of our Earth and the air we breathe is oxygen. In regard to oxygen therapy, it is administered at a concentration greater than 21%, and the goal of oxygen therapy is to relieve the symptoms of hypoxia. So that's a little basic introduction, which I'm sure all you guys know. We all recognize that we can go a month without eating, we could go a week without water, but we only can go a few minutes without oxygen. When we inhale oxygen, it goes through our nose, it goes through our mouth, and it works its way back into the lung. When it's in the lung, it goes down to the final part, the alveolar, which actually inflates, where the capillary network binds with the hemoglobin, and then the oxygen is transported throughout the body. The average adult contains about 600 million alveoli, and the reason we need oxygen, why it's so important, is that we need to produce ATP. And ATP is produced by the combination of carbohydrates and oxygen and in the Krebs cycle. Without ATP production, we are dead. We just stop living. Oxygen is vital for health. It's more than vital for health, it's vital for life. So we need oxygen. We also need nutrients. So we eat carbohydrates, we eat fats, we eat proteins, and we mix this up with oxygen, and this is how ATP is produced. ATP is produced in the Krebs cycle, and that's exactly why we need oxygen. So oxygen is vital to our life, it's vital to our health, but too much oxygen can work the other way. So it's a double-edged sword. When you think about oxygen and you think about hypoxia, one of the main organs you need to think about is the brain. The brain actually uses 3 times more oxygen than any muscle in our body. It's a massive consumer of oxygen. So as you can clearly see, the brain needs oxygen. I just wanted to give you a visual. On the left is a normal brain. On the right is a picture of a brain with hypoxia. So the brain, like I said, loves oxygen. It needs it to survive. It needs to produce all the functions it does. If you lose oxygen to the brain anywhere between 30 and 180 seconds, you may lose consciousness. At 1 minute, your brain starts dying. At 3 minutes, the neurons suffer more extensive damage, and you may have long-lasting brain damage after that. At 5 minutes, death is almost imminent, and at 10 minutes, even if the brain remains alive, a coma and long-lasting brain damage are almost inevitable. At 15 minutes, survival becomes nearly impossible. So you could see that the brain is a huge consumer of oxygen. In even short periods of it being deprived of oxygen, the brain cells will die. So this is one of the major indications for oxygen besides ATP production. Let's talk about the physiology of hypoxia. Basically, you could become hypoxic through 3 different mechanisms. 1 could be the reduced partial pressure of oxygen in the air. 2, it could be the inadequate alveolar ventilation. And 3, it could be the impaired pulmonary uptake. So let's talk about each of these in particular. When you think about the reduced partial pressure of oxygen in the air, you could think about that normal barometric pressure for oxygen at sea level is around 150 millimeters of mercury. When you go to Denver and you go to one of their mountains, the amount of oxygen in the air is 130 millimeters. And if you went to Mount Everest, the amount of oxygen in the air is about 43 millimeters per mercury. So reduced partial pressure of oxygen can be impacted by sea level or your altitude. When you talk about inadequate alveolar ventilation, that could be a whole host of conditions. If you are any kind of neuromuscular disease where you can't take deep breaths and your diaphragm is impaired, that could create inadequate alveolar ventilation. If you also think about the fact that you have pulmonary edema, that can cause it. You could also have you could be on drugs, you could be basically on morphine or some other type of opioid where you have inadequate alveolar ventilation caused by a reduced respiratory drive. When you talk about impaired pulmonary uptake, it be caused by impaired diffusion conditions such as emphysema. It be caused by a ventilation perfusion mismatch. Again, edema comes into mind. You could think about shunts. And most importantly, you can think about hypoventilation, and also could be that you have carbon monoxide, which fights for the oxygen, which is of very little use to the body. So all of these reasons cause hypoxia, and typically the treatment for hypoxia is to number one, try to figure out what's the underlying condition, and number two, you might temporarily give them oxygen to equate and make everything normal. The clinical signs of hypoxia are dyspnea. Basically, the patient is very short of breath and is like looking to get as much breath in as they can. So this results in an increased respiratory rate. Tachypnea is another example of a sign of hypoxia. Basically, when a patient is hypoxic, they end up getting pulmonary hypertension, which further decreases the oxygenation status of the blood. And some of the clinical signs of hypoxia is cyanosis, where you see bluish around the lips. You might see long-term clubbing for people who are in a state of chronic hypoxia, such as a COPD. So these are the clinical signs of hypoxia, and you should be able to recognize them. So I just put this slide in there for general purposes. I know you all really understand normal blood gases. So when you do a blood gas and you're looking for the state whether the patient has enough oxygen, you're looking for a PaO2 of 80 to 100 millimeters of mercury. So that means if you have a partial pressure of oxygen in the blood less than 80 millimeters of mercury, you are considered to be hypoxic. Let's talk about the mechanism of oxygen toxicity. When we're talking about oxygen toxicity, we are really talking about reactive oxygen species or free radicals. Free radical formation is a normal thing produced during normal physiologic processes like the electron transport chain or the Krebs cycle. So in other words, we produce free radicals very normally when we eat foods and we mix them with oxygen. So when we eat carbohydrates and we eat proteins and we eat fats and it mixes with oxygen, we produce ATP, and a byproduct of ATP production is free radicals. Under normal conditions, our bodies produce what is known as free antioxidants, and those two main antioxidants our bodies produce is superoxide and glutathione. What they do, these two antioxidants that our bodies produce, neutralizes the free radicals in our body. So when you really think about it, our bodies are perfectly designed machines that they do produce free radicals, and we do neutralize those with antioxidants. The problem comes in when we use oxygen for a patient. So when we put the patient on high levels of partial pressures of oxygen, we increase the reactive oxygen species formation, we increase free radicals, and our bodies cannot produce enough antioxidants to neutralize that. As a result of that, we end up getting a bunch of DNA damage, and we get some other damages to the body, which I'm going to get into a little bit later. But so the point is this, oxygen toxicity is caused by the overabundance of partial pressure of oxygen in the body with not enough antioxidants in the body to neutralize it. Some of the most pronounced or most biggest antioxidants we have in our body is superoxide and glutathione. Those are the super ones. And we also produce these free radicals such as superoxide anion, hydroxyl radical, hydrogen peroxide, and hypochlorous acid. All of these are free radicals. They do damage to the body, and then we actually counter that with the natural antioxidants our bodies produce. So what's the role of antioxidants in maintaining health? Under normal circumstances, if you eat right, you eat plenty of vegetables, you eat plenty of different colored vegetables, because each type of vegetable and fruit that has a different color has a different nutrient value to it. All of those are considered antioxidants. And under normal conditions, when you're not sick and when you're not getting supplemental oxygen, you are well balanced. So basically, to handle all the reactive oxygen species in your body, you produce antioxidants. In regard to antioxidants, glutathione is considered the mother of all antioxidants. There are many manufacturers who are selling glutathione as a supplement. The sad part about that is some of the evidence out there has not really shown a really significant improvement with taking supplements. Probably the best thing to do is actually eat naturally, eat natural fruits and vegetables, and have a balanced diet. Other antioxidants are catalases and superoxide dismutase, which are both really very good antioxidants. And vitamin C, vitamin E, selenium are all really good antioxidants. So I think the goal is to eat right, eat a balanced diet. And when you think about, taking supplemental oxygen in a hospital, even though it may not be your choice, or maybe when you're administering supplemental oxygen to a patient, you really got to think about things. The pulmonary insult of oxidative damage or free radicals in the lung results in alveolar damage, and this is caused by damage to actually the cell membrane. When someone is on high levels of oxygen for extended period of time, they actually show oxidative damage right on the membrane. And the pulmonary effects can present as early within as 24 hours of breathing pure oxygen. So when you have someone come into the emergency room and you put them on a ventilator and you put the FiO2 up to 100% and you keep that 100% oxygen, even 90 or 80% oxygen for 24 hours, you create damage to the lung immediately. I've been a respiratory therapist for so long, and that when I used to work in the emergency room, we would have a patient come in and we would put people on an FiO2 of 100%. I know we have gotten better over the years by lowering the FiO2, and sometimes they would stay with an FiO2 of 100% until they were transferred up to the ICU. Now, I'm talking years ago. I've been a therapist for 30 years, and, I've worked in the bedside, and I worked in the ICU, and I worked in the emergency room. So, I know that people keep the FiO2, at least back in the day, at 100% for long periods of time until they were transferred up to the ICU. But just the evidence has shown that as little as 24 hours of high levels of FiO2 can create some cellular damage in the lung. When exposed to oxygen therapy for long periods of time, you got to take a couple of things in consideration. It's the amount of time you spend on oxygen, and it's also the concentration or the partial pressure of oxygen being delivered to you. Both of these things can be toxic to the body. Symptoms of oxygen toxicity can be pleuritic pain. It could also be substernal heaviness, coughing, shortness of breath, tracheobronchitis, and absorptive atelectasis. Normally, if you decrease the oxygen, all of these symptoms will go away after about 4 hours. Other effects, such as the CNS effects, central nervous system effects, they can have a multitude of symptoms, but the most common symptom is twitching of the small muscles of the hand. Basically, you see the hand twitch and you see the small muscles twitch, and this is a CNS effect. If you really expose the patient to high levels of oxygens for a long period of time, tinnitus, dysphoria, nausea, and sometimes generalized convulsions can occur. So there's a lot of significant side effects to oxygen toxicity, and you got to be aware of this, because when you really think about it, if someone's on a ventilator, they may not be able to tell you everything that's going on. Let's talk about the epidemiology of oxygen toxicity. CNS effects typically occur in about 2% of the population, and some of them actually go into seizures. They've done much research on the CNS effects, central nervous system effects, and they actually created a name for this. It's actually called the BERT effect. So any kind of CNS effect is considered a BERT effect. And at the same time, pulmonary toxicity is referred to as a Smith effect. So they actually named the CNS and pulmonary toxicity effects with different names. The incidence of displaying pulmonary symptoms is around 5%. You all have heard of that newborns who are exposed to high levels of oxygen at birth end up getting what is known as bronchopulmonary dysplasia, which actually predisposes them to lung injury and damage throughout their life. Actually, another is a chemotherapeutic agent called bleomycin actually increases oxygen toxicity too. So oxygen toxicity is pretty common, not at real high numbers, but you still got to be aware of what's going on. So I'm going to give you a short review again of the pathophysiology. Free radicals are a normal product of the Krebs cycle and metabolism in the body, especially in the mitochondria. But when you give a patient oxygen in the ICU or anywhere else, you could actually give them oxygen toxicity. So oxygen-derived free radicals are a cause of oxygen toxicity. Free radicals are again formed normally in the mitochondria due to normal Krebs cycle and metabolism to produce ATP. It also is produced by phagocytes in the body. So anytime you have an infection, there's an increase in free radicals in the body. Free radicals create what is known as lipid peroxidizers, but basically these are free radicals that actually attack the cell membrane, and they actually modify cellular enzymes. And the other reason for cause to the lung damage is basically to the pulmonary epithelium, where it inactivates surfactant and actually forms intra-alveolar edema, interstitial thickening, fibrosis. And so basically there's a profound effect on the physiology of the lung caused by oxygen toxicity. And especially the longer that you keep the patient on high levels of oxygen, the greater likelihood of damage. Oxygen toxicity does some further damage to the lung, such as it develops into pulmonary edema, congestion, intra-alveolar hemorrhaging, and pulmonary injury. There's also cases of surfactant interruption and epithelial injury, which actually produces cytokines and other pro-inflammatory mediators, which creates an inflammatory process in the lung. They also have looked at the alveolar of these patients with oxygen toxicity, and they have like what is known as like pulmonary edema. They have this pinkish material characteristic of pulmonary edema. And the alveolar walls are actually congested with many red blood cells. So there's all kinds of physiologic histopathic changes in the lung tissue as a result of oxygen toxicity. There's a term called toxicokinetics, and basically that means how long will a chemical stay in your body, how long will it metabolize, and what kind of damage it'll be done. So they have found that 100% oxygen can be tolerated anywhere from 24 to 48 hours with any kind of severe tissue damage, but anything after that can create some kind of damage. They said that most patients who have any kind of symptoms from oxygen toxicity can be relieved within 4 hours of exposure. So basically, if you shut off the high levels of oxygen, the pulmonary insult and the CNS insult will be less in typically around 4 hours. You could do a physical examination of the patient and you could ask some questions, and the typical symptoms could include disorientation. You could have a little shortness of breath, a little dyspnea. Sometimes you actually have visual changes of myopia and cataract formation because oxygen toxicity does impact the eyes. In regard to the central nervous system, you might have headache, you might be irritable, you might have some form of anxiety and dizziness. You could hyperventilate, you could be shivering, you could feel tingling in the limbs, and sometimes you get tinnitus and you get other type of hearing disturbances. You could get nauseated, you could twitch. All of these things are physical characteristics of oxygen toxicity. There are many reasons why a patient may need oxygen therapy. For example, if you come into the emergency room and they intubate you, they need to put you on a ventilator. And when they do, they're not going to actually put you on 21% FiO2. So the idea is to put someone on a ventilator, start them off with an FiO2 of say 60%, get a blood gas, and then make adjustments after that. I would not keep someone on a ventilator at high levels of FiO2 if their blood gas proves otherwise. Another thing is if someone comes in and their resting saturation on room air is less than 88%, that patient needs a nasal cannula or simple mask. If their PaO2 is less than 55% millimeters of mercury, that's another reason. Some people desat when they go to sleep. In other words, if someone hypoventilates and their sats go less than 88% at night, maybe they would benefit from a simple nasal cannula. So the idea of using oxygen therapy prudently is very important. So the goal is not to expose them to high levels of FiO2 for long durations of period. Monitor your blood gases, monitor your saturations, and set them up in the right way. Actually, some patients who develop into ARDS need higher levels of FiO2. But this lecture is not about managing a patient with ARDS, and you all know that if you have someone on mechanical ventilation, you should be working with the PEEP just as well as you should be working with the FiO2, and you should be probably using the ARDSNet protocol. If you manage someone on oxygen, please keep track of their saturation, like say less than 88% needs some kind of supplemental oxygen, but you don't need to have someone satting at 97, 98 all the time. Anything above 92 would be perfect. If you need to manage someone, if someone shows any kind of oxygen toxicity like seizures or shaking, you really need to lower the FiO2. There's some precautions that have got to be done with patients on hyperbaric oxygen therapy. Sometimes they need anti-epileptic therapy. Sometimes because they have prolonged exposure, you really got to keep an eye on what's going on with them. And the best thing to do to manage oxygen toxicities to have protocols, and your protocols should be speaking to your PaO2 levels and your saturation levels. So this is easily managed. Everyone who hears this presentation, I'm sure, can manage patients with oxygen therapy, but we need to go away from the fact of putting someone on 100% and keep them there at long periods of time, especially someone on mechanical ventilation, which we may want to consider using higher levels of PEEP. So let's get a little bit more into treatment planning. You should just deliver enough oxygen therapy that will relieve the symptoms of hypoxia. And remember, oxygen toxicity could be influenced by a variety of conditions and different drugs that patients take and different procedures they have. So you really sort of need to understand and monitor someone through the, say, pulse oximetry or something. Now, if someone is on high levels of oxygen therapy and they need it because otherwise they'll be hypoxic, you may want to consider antioxidant enzymes such as superoxide dismutase, which has been trialed clinically to be very successful. Many patients who are in a hospital, part of their normal treatment plan is to give them antioxidant therapy. Sometimes vitamin E, vitamin C have been found to be really beneficial to the neonates in regard to retrolental fibroplasia of infants who are in hyperoxic therapy. Basically, what you want to do is prevent eye damage to the children, to the pediatrics and to the children through the supplementation of vitamin E and C if you're going to use high levels of FiO2 to manage them. Let's talk about managing a patient on a ventilator in regard to oxygen. To avoid oxygen toxicity, you really need to keep the FiO2 on a patient at an acceptable level. So if you're having a patient comes into the emergency room and they intubate them, a good FiO2 to start with would be 60%. You put them on 60% FiO2, you wait 30 minutes, you get a blood gas, and then you could titrate the FiO2 up and down based upon that number. Another important consideration is PEEP. You really need to keep the proper PEEP level. For example, you can't have a patient in the ICU with an FiO2 of 70% and a PEEP of 8. You're really doing more disjustice to the patient than you really know. So if you need to manage a patient, keep the FiO2 at a lower rate. And to do this, you may want to incorporate the odds in that protocol, which is low FiO2, high PEEP, and you could actually prevent oxygen toxicity. They have shown studies that patients who are critically ill often benefit with lower PaO2 levels. In other words, having a PaO2 of greater than 60% or greater is acceptable. Having someone whose SATs is 88 to 90 is acceptable. You don't have to have someone SATs at 97%. They actually call this permissive hypoxemia, where someone will benefit from lower levels of FiO2, actually preventing oxygen toxicity. So know how to manage your patients, use low FiO2, use PEEP effectively, and you can't go wrong. This is a study showing what I was telling you about, how keeping someone's SATs between 88 and 92% is good. That what is called permissive hypoxemia. So they did a randomized multi-center study which compared conservative oxygen strategy for mechanically ventilated patients. So this was a randomized controlled study. It was an international study, and it compared two different delivery systems. One, they kept the SATs between 88 to 92%, and the other group, they kept the SATs above 96%. So basically, they randomized two different groups. Half the group, they maintained the SATs between 88% and to 92, and the other group, they had to keep the SATs greater than 96%. They looked at 357 mechanically ventilated patients who they expected to be on a ventilator for greater than 2 days, and from that they got 104 patients. So what they did is they randomized them to two groups, one to keep the SATs 88 to 92%, and the other group they kept to 96%. And they found that the development of multiple organ dysfunction, worsening lung injury, and other adverse clinical outcomes were the same. So basically, they found no kind of difference between the management of the patients and their prognosis with lower FiO2. But as I've been explaining this whole lecture, oxygen toxicity is a problem. So if you can manage a patient and have the same outcome with a lower FiO2, that's the way to go. So I want to drill back into you exactly what the problem is with high FiO2s. Number one, oxygen toxicity can cause a variety of complications affecting multiple organs in the body. There are CNS complications, mostly with convulsions and twitching and amnesia. There's also pulmonary complications, which can range from tracheobronchitis to absorptive atelectasis to diffuse alveolar damage that is indistinguishable to ARDS. You could have ocular complications, such as delayed cataract formation and retrolental fibrosis. You could have pulmonary issues, patients with COPD, status asthmaticus, myasthenia gravis, and all these other patients who have like sort of respiratory depression can really have more problems with high FiO2 than other groups. Also, oxygen toxicity can cause what is known as carbon dioxide necrosis, which is secondary to the loss of hypoxic drive and decrease in ventilation. You all have heard of this, that you don't give high levels of oxygen to a COPD, and the reason for that is the carbon dioxide necrosis. So there's a whole host of reasons and complications why you don't want a high FiO2, and I hope this presentation sort of brought to light some of the things you got to do and also some of the management strategies that you need to do with them. So let's talk about patients who've been using high FiO2, have some form of oxygen toxicity. What is the prognosis? What is the likelihood of them having a meaningful survival? In adults, studies show that typically there's no long-term neurological damage from the result of high FiO2. Also in adults, there's most pulmonary toxicity is reversible. So like I said before, around 4 hours of decrease in FiO2, you can reverse most of the damage. In infants, it's a different story. There's a higher level of bronchopulmonary dysplasia, which actually can cause more damage to the lung long term. So really, you got to watch high FiO2s, especially with the neonates. They also show that high FiO2 use in infants will lead to respiratory infections for the rest of their life. So there is some kind of pulmonary insult to the lung as a result of that. Another worry for children is retinopathy of prematurity, ROP, and you really sort of need to decrease the FiO2 because you're going to create some later stage damage to the eyes of the neonates. So it seems in adults the insult is less severe, but with infants it's really more severe. And I worked in both adult care as well as neonatal care, so I know a little bit more about both. So if you do happen to be in neonates, be a little bit more careful. So in summary, I'm so happy that you joined my presentation. Oxygen is vital to maintain life, and if you use it in a medical setting where someone is hypoxic, it could be really good. Just keep a careful eye on what you're using, how much you're using, and how long you're using it. You really need to understand the CNS and the pulmonary effects of oxygen toxicity, which I sort of went into in great detail. And you can manage mechanically ventilated patient with permissive hypoxemia, meaning you don't have to have someone on mechanical ventilation with an FiO2 of 100% and a PaO2 being 200. when you could really manage them with much less. And that's what is known as permissive hypoxemia. So I hope you enjoyed this presentation, and there's so much information if you ever look on the web on this topic. I want to thank you for joining my presentation. And if you want to get some good references on understanding oxygen toxicity, these are 4 great references. I also want you to pay attention if you work in the neonatal area. Supplemental oxygen can be really quite deadly, so you really need to know how to manage it. So I want to thank you all for joining my presentation and hope to see you again.